Hi, everyone, and welcome to the channel. And today we are going to discuss how do you actually pass an examination, and especially a clinical examination for a post-fellowship exam or a fellowship examination, and what are the essential parts of that. And we've created 10 tips for you to take you sequentially from the front to the end so that you come out with a success. And these steps I've learned over time giving exams, and these are very useful. And we'll start off with what I think are the essential tips for taking an exam. And if we go forward in this, and the first step, if we go on to taking an exam, is the history should point to the diagnosis. And if I just start off saying that, if I say the vision is, obviously the patient's main complaint is either the vision is going to be going down or there's going to be any other thing happening, such as the eyes protruding out. And whenever you have one thing, you need to go and correlate with the other thing, which is it a painful loss of vision or is it a painless loss of vision? And the third most important thing is, what was the onset of this decrease in vision? So suppose I have a patient with the diabetic retinopathy, and I know the diagnosis is macular edema. So if I take retrospectively backward, I would say the patient presented with gradual decrease in vision, which was painless, and it was associated with metamorphopsia or distortion in vision because of the macular edema. And the things which you will say negative in this part is that probably the patient did not have any floaters or in front of his eyes, and that this was not affected in dark light. But obviously the worsening things could be because it is a macular disease that it gets worse, and if it's obviously there's glare, he'll have difference in vision. Similarly, another example, if patient comes in, complains that I've got painless sudden loss of vision, and he's associated with floaters, and those floaters are painless and they're sudden, then you need to know that maybe it's something which is a vitreous hemorrhage, or they're just floaters because of PVD. So how do you differentiate between that, and what positives and what negatives you need to add in that? Well, the positives would be adding the patients that are diabetic, and then the second one is the patient started with few floaters, which then led to the complete loss of vision. While in a patient with, and the negatives would be that he did not have any flashes of light, and while if the patient had PVD, then he would say that the patient complains of sudden onset cobweb coming in front of his eye, and it is associated with flashes and floaters, and the floater remains stable. It moves when you move the eye, and it has been stable, and the patient does not complain of any significant change in vision. So that tells you that he's got a PVD, and the other thing you need to ask is, does he have any curtain in front of his eye that would differentiate this from a retinal detachment? So in history, basically, you telling the examiner what you have understood from the patient's history so that you can come with a logical diagnosis. I'm not going to go in detail about their family history or his occupational history or his social history. All are very important. I think the most important things which you need to always check in those are if the patient has diabetes or hypertension, hyperlipidemia, any other systemic disease, any treatment he has taken. In order to keep this short, I'll just briefly outline things. And obviously, there are many discussions which you can speak like 15 minutes or half an hour just on history. The next step is an examination. So when you start off, after you said, I'm finished with the history, I want to hear that this is what it's pointing to. And now you start off with the examination. Examination can be divided into 3 or 4 steps. The first step is going to be Your external examination things which you need to do. The second is going to be slit lamp. The third is going to be the indirect, and the fifth is going to be your slit lamp examination or any external examination if you've got a patients which has got an orbital disease or a squint patients. Obviously, you need to do other things for that thing. But this is just for standard for all patients which you need to do. The external things which you need to do is the visual acuity and be careful that you do all the types of vision. You need to do unaided, best corrected, distant visual acuity on a Snellen chart. The next thing is a near vision, which you need to do on a Jaeger chart and tell what you have. And if you think that the patient's vision is not 100%, then you need to add a pinhole with that as well so that you know that the patient is not getting corrected with that. Once you've done that with the clinical method, I think there are certain tests which examiners are looking that you need to do, and those are very essential and you need to quickly do them. Then those will include, after doing your vision, you need to do your peripheral visual fields, you need to do a pen light, a pupillary light reflex test, extraocular movements, a cover test, an uncover test, and a digital tonometry just to have a bearing of what is happening. And once you've done these maneuvers, then there's a few other things such as the Amsler grid and color testing. Those are important because Amsler grid is going to tell you that the patient has got macular disease, while a color vision is going to test you that this got an optic nerve disease. So those, don't forget those, because once the examiner is going through that, he is going to mention that, have you asked for those? And then the specific tests for different diseases, like if you've got an orbital disease, obviously you need to do a Hertel exophthalmometry. If you have a patient of squint, you need to do a prism bar to do that. You need to do a stereo acuity in those patients with a titmus fly or a Lang test. Those are just examples of the specific tests of different diseases which you need to know, especially in external eye diseases. After you finish with these tests, then if we go forward to the next test is examination with a slit lamp. I think that is a crucial part of your exam. You need to give a lot of time to this examination, which is going to make your differential diagnosis and your diagnosis on which you're going to make your treatment strategy. So you start off with just looking before you sit on the slit lamp externally. If the eye is straight or is deviated, you've already found that on a cover test as well. But once you start off, you look at the lashes. Most probably there's some blepharitis always available or seen in patients. Then conjunctiva, you need to know that the conjunctiva is covered by lids, and you need to move the eyelid hold the lower lid down and then hold the upper lid and ask the patient to move down and to the right and left. You need to see the forniceal conjunctiva in all quadrants. Especially if somebody's got a vitrectomy, you probably will see marks from vitrectomy as black spots on the sclera in these patients. Once you've got the conjunctiva, then and the cornea is very important. Cornea, I think if there's a corneal opacity, you need to know the thickness, the depth of the opacity, the size of the corneal ulcer. Is it active or non-active ulcer? And there's some degenerations which are normally seen in the cornea, which you should not miss. It's just a positive point for you. It's like arcus senilis is always seen there, is present. Patients might have corneal guttata, which are visible in older patients. You sometimes have Hudson star line. You get crocodile shagreen. These are the degenerations which you see in these patients. Then looking at the anterior chamber, you need to look at the depth of the anterior chamber. Von Herrick is a very good example, very good way to check quickly for the angle. And if you think that the ankle is compromised, you must ask for a gonioscopy, which you need to do at the end of the procedure so that other visualization is not compromised. You need to look for any peripheral anterior synecdoche. At the limbus, you need to see if there's a corneal scar, the phaco scar mark. Where is the phaco scar mark? And was it extracapsular surgery? Are there any sutures present over there? If there's any limbus sutures present, the examiners sometimes like to ask if there's a vitrectomy. Do you see the old scars of conjunctival wound healing over there as well? Then you go on to the anterior chamber. You probably might also want to see any of the posterior bowing of the iris in patients with pigment dispersion syndrome. Retroillumination for iris is essential if you want to pick up very small Yaga iridotomies. In olden days, they used to be very big ones, but nowadays some people do temporal at 9 o'clock. Those iridotomies are very difficult to pick up unless you do retroillumination. So you need to do a diffuse illumination, a retroillumination, and an oblique examination with the slit lamp, and you can also use a sclerotic scatter as well. While when you're looking at the lens, if the pupil is dilated, you're going to look if there's got nucleus sclerosis, posterior subcapsular cataract, or there's cortical spokes present and because of the lens opacities. And the other thing is the lens centered? Do you see the zonules? Is there any subluxation of the lens in that area? And once you know the lens, if it's a pseudophakic patient, then you need to know, is the lens there? What type of lens is it? Is it foldable, rigid? Is it multi-piece IOL? Is it in the bag? Or is it in the sulcus? There's a posterior capsular opacification. There's anterior phimosis present in that patient. You need to know everything in these patients. Is there a posterior capsulotomy done in those patients? And once you go onto the vitreous, I think vitreous is you need to look for pigment cells, other cells for intermediate uveitis. But the important thing is always look for a PVD. PVD will either be seen as that Weiss ring at the back, or sometimes you can see in the vitreous as the crinkling of the vitreous over there. So here you are seeing in the vitreous, anterior 1/3 of the vitreous is with a slit lamp, and while going backwards, you will be using a 90 diopter or superfield or 78 diopter lens. And when you're looking at the retina, make sure that you first start off looking at the posterior pole, look at the blood vessels, the temporal blood vessels, and then the peripheral retina, which you see over there, asking the patient to look in all directions. And if he has a macular hole, then don't forget that Dvorsky-Allen sign over there in that patient. And I think optic disc probably you can do at before starting the retinal exam or the end. But if you know that the patient has glaucoma, then optic disc examination needs that you need to tell them the cup to disc ratio, the pallor of the rim, if there's any peripapillary atrophy, if there's any bennetting of blood vessels, if there's a lamellar dot sign over there, nasal shifting of blood vessels in the optic disc, if there's any blurring of the disc margin, any optic disc-trusion, so optic atrophy, and the cupping, you need to see if there's a shallow cupping or a deep cupping. And you can also see NVD in this area. So it is a big area, but sometimes we are very careless to overlook things which we can easily see in the optic disc. Then examination once completed with the 90D, you can go on to the indirect examination. And with the indirect examination, it's required that you ask the patient to lie down on the couch and you go on over to the head end and set up your indirect ophthalmoscope. If you have your own indirect ophthalmoscope, which can be costly, but it usually that makes you very comfortable during the exam, and you need to use either a 28 or a 20D lens. You need to look at the posterior pole, initially identify the disc, the posterior pole, and the blood vessel. Sometimes it just might be a macular disease the examiner wants to see on the indirect. Then looking at the periphery, asking the patient to look in all directions again, and then drawing it on a paper is very essential. You can take a retinal drawing paper to document what you see with the colored pencils. And then the last one is indentation. And then you can ask the examiner that, shall I do indentation? Or somebody might say that that is enough that you see in the periphery. The most important part in indirect examination is with the retinal detachment, you must try to find a hole. Usually, the exam cases have a hole, and if you do not find a hole, then be ready to answer the reason why you couldn't find a hole. Holes probably sometimes are not seen in inferior pseudophakic or aphakic detachment because they got very small micro holes in these patients. The next one is tonometry, which candidates sometimes forget because they run out of time at the end. But please do keep the last few minutes, 5 minutes for the tonometry, and do know how to do the tonometry because examiner do know what the exact pressure is. And if you're not able to find out what that is, then probably that's a very essential part of the examination, which is missing. use fluorescein strips. You can use fluorescein strips after putting the local anesthetic and give some time for that fluorescein to diffuse and the tear to sort of uh, drain out so that you can get the tear meniscus, which is a right thickness rather than very, if you do examination with very dilute or with very teary eye, you tend to get very thick menisci, which give you inaccurate reading. And align your slit lamp, hold the patient's eye. Some people try to do it without touching the eyelids. Probably I would recommend holding the eyelids, but you need to understand that you need to hold the eyelids from the brow. So what I would do, I would just hold my finger over the rim and then hold my finger over here and pull the skin over this area rather than holding the lashes. And then if I cannot hold that area, I go down and pull it up more and then pull it in the lower lid as well, because you do not want to press with your hands on the globe, because that will going to increase the intraocular pressure. And take your reading with looking at the tonometer below. Sometimes examiners can ask, how do you calibrate a tonometer? Time management. I think one thing which can make you pass or fail an exam, that is time management. For the sake of easiness, I said you can break the examination or your history taking and everything into 10-minute steps. So if you divide your first 10 minutes into history and external exam, so you need to cover your visual acuity, your extraocular movement, cover test in that area. That will give you a very good time. Sometimes patients tend to be very elaborate and how they're going history. You can just ask them initial question, and you can keep asking them while you're doing a slit lamp examination, other things in that area once you're going the examination. And then once you go on to the next step, that next step is going to be a slit lamp examination, which I think you need to get 10 marks, because you need to do that oblique, the diffuse examination, and you need to do the retroillumination to check for the different things which you're getting. Use anterior segment. You need to take time for 90D, get comfortable with the slit lamp, try to get your findings right, draw your finding, because examiners sometimes can ask you to draw your finding, because sometimes people get confused. What they see with the 90D is opposite to what they'll see after reinverting. And then indirect and tonometry, keep 10 minutes for that, because sometimes the indirects are less in exam hall. So there might be crowding over that area, so just keep yourself. So as soon as you're done with the slit lamp, immediately go for indirect and tonometry. If you pace this out in this way, I'm sure that you can do very well. You keep yourself time for something. If they're missing, you can always go back and recalculate your step if there's anything wrong. Once you've done that, the history and the examination, your 30 minutes are going to be gone, and then you're going to be sitting with the examiner taking exam, and that will be starting off with, you're going to tell your history and your examination tips. And once you finish with that, you come on with a differential diagnosis and what are your logical conclusion for the differential diagnosis. This is very important, to come up with the most probable diagnosis first rather than the least probable diagnosis first, because that tells you your clinical acumen and your thought process is how you're thinking on what you're going to do. And then be able to justify what you are saying and how that is more applicable to this patient. So differential diagnosis is very important. Have a look at different books which give you differential diagnosis and just memorize those so you can have an idea of what to show differential diagnosis in different cases. Then you need to go on to investigations and be prepared to ask them in two different steps. One is systemic investigations, which will include blood examination or X-ray examinations or other examinations which are justified, which are non-ocular, which might include HRCT for a patient with sarcoidosis or a bone marrow biopsy. But then you come on to ocular investigation. I was recently taking an exam, and I asked, what investigations would you like to do with a patient of paralytic squint? So sometimes you get confused. You need to say that HES chart is something which you need to do for that. You might need to say binocular vision mapping as well in those patients. But the most important test which we have is the OCT, FFA, B scan, um, and the newer modalities are also important, like angio OCT, wide field or the ultra wide field cameras, which includes the optos, which will give you a 120 degrees picture of the retina, and the RetCam, especially in patients with retinopathy of prematurity. And you always need to give whatever investigations you're going to do, what justification are you going to give to that uh, uh, for that justification for that case you saw, and why you ordered that investigations. And once you've done with the investigations, then you're leading yourself towards the treatment. And be careful that if the examiner keeps you in the investigation and the differential diagnosis and you're not coming up with a differential diagnosis, that means that you need to make corrections. They tend to give you clues where you're going wrong. So you need to come up with whatever treatment, because your treatment should be what the diagnosis is. Because if you say treatment for something else, then you would be obviously saying things which are not correct for that particular patient. And the examiner wants to know what would you like to do for that patient, not for that disease. So if somebody's got a CRVO, which is fresh, so you need to tell them what you will do it rather than telling them what you'll do for a chronic patients of CRVO. And start off from medical treatment, then go on to surgical treatment. So you go on from early steps to the difficult steps, which you go on forward. The steps which you need for surgery, you need to know the basic steps for cataract surgery, for even retinal surgery, for retinal detachment surgery, for vitrectomy, for lid surgery, for orbital surgery, how you would do the incision, where would you localize that lesion, how you remove that. And they need to be logical and they need to be stepwise so that they know that you are able to do that. I think argon laser is one thing which you need to know very in detail, that how many burns you want to do, what is the energy level you need to have, what is the interval, and how can you reduce the pain of the patient. If the patient has pain, what measures can you take to improve, to complete that procedure. And once you've done with that, then you know that the patient, that you've gone through your exam successfully at that point, and you're coming up to the complications. You need to know if you leave the patient untreated, what complications can you have? And the other are, if you treat the patients, so what are the complications in patients with the vitrectomy? So you can tell them that you can get a per-operative complications, you can get early post-operative complications and late post-operative complications. You need to always stratify these in that groups. And then if there are any newer techniques available for that, such as anti-VEGF, so you can say faricimab is another newer anti-VEGF which is available. So always have an idea what newer treatment modalities are available and try to put that forward in your examination cases and whenever you come up with the techniques. And the complications are very important, and you need to know, how to counsel for these complications, or you need to either know how to counsel for either complications or counsel for any hereditary disease, any tumor, or for even doing surgery, a complicated surgery with poor visual outcome. And those are the 10 tips. And once you've done those 10 tips, I think you should be able to be ready to pass the exam or be very near to that area. And other things which are very essential to get that final click is be smartly dressed, look fresh, take a good sleep at night, carry your own instrument, be aware of what instruments you're using rather than fumbling around with your instrument. Be very courteous to the patient. Patient should not complain of any pain. Ask for anything you think is necessary. If you cannot find an indirect, if you need a tonometer, just ask for them rather than looking around that I cannot see it and wasting your time. And listen to the question the examiner is asking and then answer carefully. Sometimes you can take a short breath, short stop and just think it and then say, this is the things we are going to do, and think around what you're saying, and the examiner is giving you some cues, try to think over and come up with a restructuring of your answer at that time. Just don't overlook an examiner. Sometimes they very rarely they would be taking you to a wrong side, but usually they'll be there to pass you, and they'll be sort of most willing that you should be able to give the correct answers. So be logical in your response, come up with the most common things, and come up with the most used treatment techniques and how you're going to manage that patients which you are seeing in that day. So I think best of luck for your exam, and always be alert and practice. Practice your long case before going to the exam, and that I think if you help memorize the tips I mentioned, I think that will give you a headway of passing the exam, and hopefully you won't have to come to the exam again. Your first attempt is always your best attempt. So make the best effort, first go, and go for the victory. Thank you. हाँ जी।